Thank you very much, Anwar. Yeah, Rod quite nicely set the stage, so I have a little bit more time on certain aspects to go into more detail. So thank you very much for having me present here, and I thank Johnny for organizing a wonderful meeting. So when you look at molecular imaging, what you're basically doing is looking at a number of features of the tumor phenotype. You can target the tumor cells directly by either targeting membrane-associated receptors and transporters. You can look at intracellular processes, but you can also look at the immune cells, which is becoming more and more relevant in these days with targeted immunotherapies. You can look at the microenvironment, but you can also look at tumor-host interaction in PK/PD studies, which may become more relevant in the future when we start systematically using molecular imaging in response monitoring. Rod already touched on it. Let's say when you're imaging the tumor phenotype in prostate cancer imaging, you have a plethora of agents that are used, misused, not enough used, and it's quite confusing in that area of prostate cancer imaging, which agents to use, because the literature is also quite confusing in terms of the pre-selection of patients that were entered into studies. So probably it's fair to say that the choline agents are around for the longest time. They look at membrane metabolism, so they're non-specific. You can look at membrane epitopes such as amino acid transporters. There is a compound out, FACBC, which is used and even approved for prostate cancer imaging in the US and in Europe. The membrane epitopes, of which the PSMA is the most important in prostate cancer. And we have antibodies against PSMA, but also small molecules, labeled with a variety of radionuclides. We can target the androgen receptor, which is an intracellular target with testosterone derivative FDHT. Don't forget FDG, which is especially useful in dedifferentiating prostate cancer. And those of you who regularly perform FDG PET-CT, very often you have that occasional lesion in the prostate that you pick up that proves to be a prostate cancer. And if a primary lesion in the prostate is positive on FDG, it's highly likely that it is a significant cancer because the insignificant cancers are FDG negative. And we have the obvious bread and butter in molecular imaging, that is the bone scans, because they are part of the guidelines. And you know why CT and bone scans are part of the guidelines and why they are so resilient, while everybody in the imaging community is already looking beyond, looking towards MRI, looking towards PSMA and other agents. CT and bone scan are in because all the clinical trials on the drugs that are routinely used for treating patients with metastatic prostate cancer have been done staging and restaging the patients with CT and bone scan. So the moment that we come in with multiparametric MRI, whole body MRI, PSMA PET-CT, all these results from the clinical trials with drugs become very difficult to interpret because we pick up much more disease and we put it in a different perspective. So the whole connection between the staging of the patient, the therapy chosen, and the outcome is lost. So what we basically are doing is we're helping the urologist, we're helping the radiation oncologist, but we're confusing the medical oncologist. So the most opposition to innovation in prostate cancer imaging, both local as well as distant, but especially distant, will come from medical oncology because we'll make their life quite difficult, which, by the way, I like. So here are a couple of examples of what is around, and I'll address these subsequently, let's say not going in too much detail where Rod already indicated it. We have PET, we have SPECT, but I will focus on PET here. So, as said, let's say choline is a non-specific biomarker. It's biosynthesis of phosphatidylcholine, so it's a component of the cell membrane, and prostate cancer cells happen to have a higher turnover. It's an old tracer, 20 years old, and we have variants labeled with carbon 11 and F18, and it really depends on the proliferation of prostate cancer cells. If the membrane metabolism is slow, you get low uptake, and that makes it sometimes challenging to pick up the lower grade tumors. So it's very well known that the sensitivity in low volume disease at low PSA levels, where you want to make the difference, is pretty low. That doesn't mean that choline cannot be helpful. There are still many countries where PSMA is not available. Italy is one example where you can only use PSMA basically in clinical trials, and you cannot use it on a patient indication basis. And there are countries where it's very, very widespread, like in Australia and in Germany and in the Netherlands, where it is, to my opinion, it has a tendency to overuse even. So, choline PET-CT in rising PSA is basically a problem solver. It's been positioned there when, let's say, conventional imaging doesn't really provide you the answers. You have to be very careful in patients, prostatectomy patients who have a PSA rise and the PSA is still below 2, because there is definitely a sensitivity issue, and if it's below 1, we have to be very careful because the pre-test likelihood of a false negative test is quite high. And this is the original publication from Hara, who developed choline for brain tumors, and then found out that it also was very useful in prostate cancer. 1998 it was published. And you've seen this meta-analysis that was performed a couple of years ago, and it is highly unlikely that, let's say, the very good results in literature are basically representative of the average patient population where we use the choline. So I think that a lot of the choline scans are done in patients that are not appropriately pre-selected. If you don't do that, the results will be disappointing. If you do pre-select the patients well, it is a problem solver. So I wouldn't fully discard it. If you have PSMA, it's probably justified, like Rod said, to terminate the choline program and to move to PSMA, but there are exceptions, and I'll talk about that a little bit later. So the little bit of drama around FACBC, flucyclovin, an amino acid, which has been approved for use in prostate cancer. The approval came by FDA and EMA the moment that the PSMA wave hit us coming from Germany. So an agent that is approved for routine clinical use with quite a broad indication was facing a new development that was clearly superior. And here, this is a perfect example of what is happening in molecular imaging. The flucyclovin was developed 15 years ago for brain tumors, and the first report on prostate cancer was in 2007. And then it takes 10 years to bring an imaging agent to the clinic as an approved agent, which is way too long to match the dynamics of everything that is going on into imaging. It appears that the utility of flucyclovin is in the same ballpark as choline, so let's say pricing of the compound will become an issue, and flucyclovin isn't particularly cheap, so it's going to be a challenge to get this product advanced. So here is an example, the typical examples that are shown for all the agents. A pelvic sidewall nodal metastases picked up by flucyclovin. And remember, it is as non-specific as FDG and choline because you're looking at protein synthesis here. There was a study on the direct comparison of FACBC with choline, carbon-11 choline, and it appeared that the targeting was higher than the carbon-11 choline, but if you do the numbers, the pickup rate isn't really significantly different. An interesting agent is the FDHT, so it's a labeled testosterone analog. You directly go after the expression of the androgen receptor, and because it's an intracellular target, it's a bit challenging to develop the tracer because it first has to go into the cell and then stick there. And although it's highly unlikely that imaging the testosterone receptor will be of relevance in routine clinical imaging, there are interesting phenomena that will probably position this agent in drug development, because you see the flip-flop phenomenon that lesions that have a low FDG uptake have a high expression of the androgen receptor, and vice versa, that when the androgen receptor gets lost, the FDG uptake goes up. So if you're after the androgen receptors in terms of treatment, it can give you quite useful information on heterogeneity, and especially the prevalence of heterogeneity. It doesn't mean that you have to do FDHT scans in all patients, but if you develop a treatment, you would like to know what the heterogeneity in your patient population is when you're developing your drugs. So there may be a niche. As already indicated, PSMA is the buzzword these days in molecular imaging of prostate cancer, and it has a very attractive pathophysiological background. So the PSMA expression on the cell membrane is controlled by the FOLH1 gene, and the FOLH1 gene is under direct control of the androgen receptor. So if the androgen receptor is blocking the FOLH1 gene, the PSMA production is low and the translation to the cellular membrane is low. The moment that that axis breaks, so that the sensitivity of the androgen receptor, of the tumor to androgen receptor blockade is lost, you see that the FOLH1 gene gets activated, and you get a lot of PSMA production and expression on the cell membrane. So pathophysiologically, it's a highly interesting target, because with the increasing aggressiveness, you see the PSMA go up. There is a word of caution, because 10% of the patients have intrinsically negative PSMA prostate cancer. So these tumor cells never did and never will express PSMA, because it's just not there. That gene is not active. And that means that whatever you do, no matter how aggressive that tumor is, you will not see it at diagnosis, and you will not see it when the patient dedifferentiates and becomes metastatic. So these are called the false negatives, but in fact, we don't pick up the disease, but we cannot pick up the disease when the keyhole where the key is supposed to fit is missing. So it's a known caveat that we have to deal with. So looking at the targeting, it's the antibodies versus the small molecules. The antibodies are pretty attractive because it allows you to assess the dynamics of the PSMA targeting over time. However, it does take time. It takes 4 days to obtain your scans. You have to go use radionuclides that are not readily available and relatively expensive. So the antibody route for prostate cancer has been explored by a few institutions, but is unlikely to progress to clinical practice. So the small molecules are clearly the winner. The initial one, the gallium PSMA, is is most heavily used, you have to be aware that there are several derivatives, and there are also derivatives out there that, that bind the radioactive gallium with another linker. And that linker is pivotal. There are compounds out there that are hardly effective in targeting lesions because their affinity for the receptor is much lower. So the gold standard is the so-called PSMA-11, which was developed in Heidelberg, and I'll show you an example of that. But if someone says, I'm doing PSMA scanning, the first question should be, which one? So the good thing about PSMA, as shown earlier, is the fast background clearance, high targeting, and you're done within an hour. You have high yields in the lower PSMA range, especially in those patients with a high PSA doubling time. And this comes from the initial publication from Heidelberg and shows you another PSMA compound, the 617, which basically shocked the nuclear medicine world because of the high targeting of small lesions. And it clearly showed that we could finally target disease in a phase that we were never able to detect before. So really small lesions down to 2-3 millimeters. So there's also a fluorine variant of PSMA. The fluorine has the distinct advantage that you can transport it, so that you can have a production facility somewhere and you can ship it, like the FDG. The fluorine compounds have, in terms of image quality, a slight disadvantage. They're more lipophilic, so you see more excretion into the gut, which may be disadvantageous to assess the retroperitoneum. Moreover, the absolute targeting is lower, so you get SUVs up to 4 or 5 in nodes, while we were used with the gallium PSMA that it could go up to 20. However, the visualization is usually quite good because the background is also lower. So your contrast in the image is quite similar. I personally like the gallium images a little bit better. There have been comparative studies, and it was shown that the pickup rate for small metastasis between the fluorine PSMA and the gallium PSMA were highly similar. However, I feel that the equivocal cases in small nodes is a little bit higher in the fluorine component. Where are we going to use it? We see a tendency to more use in adding PSMA scanning to primary diagnosis of prostate cancer. I think there is absolutely no case to use this in low risk or even intermediate risk patients. And I think that in the primary staging there is a definite role when there are major decisions to be made regarding the therapeutic follow-up of the patient. So in patients where there is even the slightest hint of a disease that would prevent the radical prostatectomy, I think that would be the ideal position of this technology. The distinct advantage is the detection at low PSA values. And it was already said, size matters, but it is not just size. Targeting in molecular imaging is the product of size and expression of the antigen on the membrane. So you can have very large lesions. If they lack the receptor, you don't see it at all. It can be centimeters big nodes, no expression, no targeting. And here, in this case, you have a patient with a slowly rising PSA from 0.1 to 0.4 who was sequentially imaged. And you see that at 0.1 and 0.2, we do not pick it up. There are just not enough tumor cells in that node to become positive. And when the PSA hit 0.4, there was a significant tumor mass in that node, and we picked it up. I just want to hint at the Theranostics, because we will have a keynote lecture on that later on. The fact that you can switch the isotope from an imaging isotope to a therapeutic isotope is highly attractive to offer an additional therapeutic option to patients who are getting resistant to the common drugs. And there are several ongoing phase 3 trials now which are expected to report. I don't think that they will report next year, but definitely that they will report in 2021. And we will have agents that will be available for treatment of patients in the follow-up of the molecular imaging. And say these are just random examples taken from literature where you see pre- and post-therapy images where the patient's disease burden is heavily reduced without any relevant side effects, but Rod will go into detail later. We know that PSA response is a poor predictor of outcome, so we have to be a little bit cautious about overestimating the effect of our treatments on just measured by PSA, but let's say the PSA responses are quite dramatic. And the next kid on the block is that we switch the beta emitters for alpha emitters, where there is an even larger decline in PSA, even more tumor cell kill. And the patients do experience some side effects, mainly xerostomia, because the salivary glands also express the androgen receptor. But let's say the effects in heavily pretreated patients just falls short of spectacular. So in conclusion, we have many pathways for interrogating the tumor phenotype, and the PSMA targeting small molecules clearly have the edge at the moment. We are finally in an arena where we detect very small lesions at low PSA levels, where there is a high likelihood of oligometastatic disease and a potential for cure. We are looking at tumor heterogeneity and resistance, which is a particularly important feature because these are currently addressed therapeutically as well. And the advantage that we have that we can tailor the radiopharmaceuticals to the receptor transporter or pathway that we want to interrogate is also applicable to prostate cancer molecular imaging. And the Theranostics, I guess, we will hear all about that after the coffee break. So, thank you very much for your attention.